Assalamu alaikum. Thank you very much. I would like to thank the organizing and the scientific committee for inviting me. We'll talk about spine fracture in pediatrics and what do they behave different from adults. And pediatric spine trauma is rare. 2 to 5% of all spine injuries in all ages group. The majority of these injuries are in the cervical spine. And there's two major group ages of pediatric spine fractures, younger than 5 and older than 10. These represent the two major groups. A major difference between adults and children is the occurrence of the spinal cord injury without radiological abnormality or the square. There is a unique feature for pediatric spine. They are not adult with a smaller size. They are not adult spine. So the pediatric spine is dynamic. They are growing and they develop. Children have large head in ratio to the body, so that's why they will have more risk of cervical spine injuries than thoracolumbar. Also, they have inherent ligamentous laxity and elasticity of the bone, and incomplete ossification center give them a distinct fracture pattern. Also, children have a facet joint that is small and more horizontal in orientation, resulting in a great mobility and less stability. And also the presence of the epiphyseal plates give potential of deformity remodeling, so we can accept some deformities in the spine to heal, or it can lead to progressive deformity if damage happened to that growth plate. So its follow-up for a long period after fracture healing is important in this age. After the age of 9 to 16 years of age, the bone they gain stronger ligamentous and bone structure that provide better protection of the spinal cord, so the spinal cord injury are less, but fracture increases in this age group. I'll concentrate on the thoracolumbar fractures and some guidelines in the treatment. Compression fracture represent the largest subtype of thoracolumbar fracture in pediatrics. The wedge shape or the immature vertebral body and the natural kyphosis they have increases the risk of compression fracture in these kids. And usually there is a multiple level involved. Even in stable injuries, we have to put in our mind that progressive deformity could happen if the end plate, growth plate is damaged, and there is a significant kyphosis. So we have to follow them for a longer period of time for these progressive deformities. So fracture with minor loss of height is usually less than 50% loss. Usually the best is a conservative management of bed rest and immobilization. TLSO brace can be used and considered for non-operative management for unstable fracture, and usually it takes, we keep it for 6 to 8 weeks with a good results. The other fracture pattern is the burst fracture, and it happens in a higher energy trauma like a motor vehicle accidents. It happens when the nucleus bulbous drives into the vertebral body, leading to a fracture of the anterior and the middle columns. And with these injuries, the germinal layer or the growth plate get premature closure and could lead to a progressive deformity with growth. These are considered unstable in most of the cases, and there is associated neurological injuries. Non-surgical management can be pursued for biomechanically stable fracture without any neurological compromise, with a TLSO for 8 to 12 weeks. Surgical management should be used for cases when they have a neurological deficit or biomechanically unstable fractures. In adults, usually we go 2 levels up, 2 levels below the fracture side in fixation. Think in other pediatrics, If you do this always, they will get with a short trunk and crankshaft phenomena. So keep it in your mind before you start deciding about the levels of fixation. This is a vertebral apophysis fracture is distinct for children because they have the unfused apophysis. So it's a fracture of the ring apophysis, and some call it the slipped vertebral apophysis injury. Most commonly happen in the lumbar vertebra L4 and L5. The clinical presentation is most commonly back pain and radicular leg pain. CT scan is the best diagnostic imaging modality. The treatment is either to do a standard approach for discectomy with fragment removal, but sometimes this is unnecessarily and increase the risk of surgical risk. Posterior laminar decompression alone is at the involved level is enough to elevate the presenting symptoms. Seatbelt injury, which is a flexion distraction injury or the chance fracture, can happen in these growing children, but in adults, the usual commonly place is the thoracolumbar junction. In kids, it's lower at the level of L2, L3. And you have to consider other abdominal injuries in surveying these kids. Traumatic spondylolisthesis or spondylosis, it's a concern for pediatric athletes. The usual mechanism is repeated hyperextension with axial loading in the immature spine. This will lead to a fatigue and fracture of the bars in the lower lumbar spine. And it's commonly in gymnastic or weightlifting and football athletes. Conservative care should be the primary initial treatment with avoidance of the painful activities and avoiding the repetitive hyperextension. Surgical intervention is considered only when it's persistent, more than 6 months, or debilitating the child, or there is associated high-grade lithiasis. Surgical options, either posterior lateral arthrodesis with or without interbody fusion, and also there is a direct bars arthrodesis with pedicle screw laminar hook construct, like the picture is without any level fusion. Now, the main difference between adults and pediatric spinal injury is the presence of the sclera injury. It represents a spinal cord injury in the absence of any bony radiological abnormalities. It is the highest among the children under the age of 8 years. And as we mentioned before, the predisposing factor are the heavy head of the children, weaker neck muscles, and a great elasticity of the vertebral ligaments. The thoracic spine is much less commonly affected compared to the cervical spine, compressing only 13% of all cases. The rest are in the cervical spine. There is other two phenomena that we have to special attention is the delayed neurological deterioration after the primary injury and the recurrent sequela. Now, the recurrent sequela is can occur as a second set of symptoms from several days to weeks after the initial injury. The incidence is markedly reduced if you recognize the primary injury early and immobilize and take all the spinal precautions to prevent the recurrent sequela. Appropriate long-term immobilization can be maintained for 12 weeks with the cervicothoracic or any other type brace that appropriate for the fracture side or the injury side. Now, in the management of a thoracolumbar spine trauma in children, the decision for surgery in general is 3 factors: the need for decompression or of the neural elements, the stability of the injury, and the long-term potential for healing. For the stability, in turn, it has a variety of rules, but the thoracolumbar injury classification and severity score is recently validated for children and can be used to help you to decide to go for conservative or surgical treatment. Now, points to remember is the presence of a neurological deficit at presentation is the major factor in determining the long-term outcome. A systematic approach to the pediatric spine fracture is needed with attention to immediate stability, need for decompression, and long-term stability and opportunity of healing. Because children have more laxity of the spine, physicians must keep high suspicion of sclera. And children who are treated non-operatively for their spine fracture should be followed for a longer period of time to follow possibility of subsequent deformity develop with growth. Performing spinal instrumentation and fusion in young kids can lead to short trunk or crankshaft phenomena, and we have to keep in our mind about this complication. And thank you very much.